I want to thank the organizers for giving me the opportunity to present in this August gathering. I'll be talking about the application of robotics in minimally invasive spine surgery. We are aware that there has been an increase in incidence of instrumentation, revision, as well as minimally invasive spine surgeries. As the number of complicated surgeries and minimally invasive surgeries have increased, there has been an incidence of complications as well, whether it's adjacent segment degeneration or neurological injuries per se. Also, because of the limited field of view, there has been an increased radiation exposure both to the patients and the surgeons. Uh, the advancements in technology help to overcome these limitations, and there has been a gradual evolution from freehand to navigation to robotics in this regard. When it comes to navigation, various sources of errors and possible solutions have been documented in literature. Main concerns have been learning curve and the motion related and wobbling artifacts. Robotics is a marriage of image guidance with effector arm technology. If we were to compare the various technologies, there are various points which could be taken into consideration per se. Uh, we know that there has been an increased interest in robotic guidance, and there has been a number of publications in this regard. As you can see here, there has been increased trend towards the publications over the years per se. And a large number of publications have come in peer-reviewed journals. When we need to look into accuracy, let's first understand the difference between the various techniques. Freehand is image-based, navigation is enhanced image-based, can take planning to execution with reasonable accuracy and control. Robotics is artificial intelligence-based construct planning, and planning can take place in true AP, lateral and axial orientation. Planning can be taken to execution with robotic precision and control. Registration is not applicable in freehand. In navigation, it is a feature-based registration. Thus, registration errors can happen, especially if disc work is performed before intra-op imaging. Robotics is automatic point-by-point mapping based on grayscale characteristics of the image that the system understands. The spine anatomy is segmented and registered vertebra by vertebra automatically. The change in disc height doesn't affect registration, as registration is done level by level. When it comes to execution, freehand is based on direct visualization, knowledge of the anatomy, experience and tactile feeling. There is less control and variable outcomes. Whereas navigation is based on virtual navigation visualization and is a partial freehand technique. Robotics, on the other hand, is based on robotic guidance combined with navigation visualization. It is fully robotic arm guided and highly predictable and with superior outcomes. Due to this, there have been very high rates of accuracy up to 98 to 99%, which have been quoted widely in the literature. This is specifically for MIS, the literature that I'm showing you per se, largely documented well, and navigated robotic assistance especially also has shown a very high level of accuracy per se. And this is not only in simple MIS cases, but high-grade lumbar spondylolisthesis as well. And this study on adult spinal deformity also showed a high rate of accuracy and minimal complications with an MIS technique per se. Now, when it comes to fluoroscopy, it has been well established that robotics reduces the radiation both to the patient and to the surgeons up to 50% from navigation and up to 70% from fluoroscopic guided spine surgery. And this has again been well established in the literature per se. When it comes to complications, screw revision and revision surgery, there were significantly fewer complications and revisions with robotic guidance MIS. This is also well established in the literature. And this study showed that measured robotic guidance was found to have a 5.8 times lower risk of a surgical complication and 11 times lower risk for revision surgery per se. And again, in this study, they were able to show that the misplacement rate was far less. And this retrospectively matched control analysis also showed a lower complication rate. One would tend to be apprehensive of loosening in osteoporotic patients, but this study on robotic assisted surgery in osteoporotic patients showed that the screw loosening rates were low here as well. So there are various studies like this which show less incidence of complications, less blood loss, longer operative time in MIS. This study compared MIS TLIF versus robotic assisted OLIF and also found good comparable results per se. Wound revision rates have also been found to be low with robotic guidance surgery in pyogenic spondylodiscitis. Now, improved patient outcomes have also been amply documented in the literature, mainly due to improved implant accuracy, reduced radiation, but also reduced complication rates, reduced reoperations, and reduced average length of stay. This study showed that robotic assisted percutaneous pedicle screw placement could be done under regional anesthesia. The feasibility and safety was well documented with this study, and another study which showed that ability of navigation or robotics to enable spine surgery in an ambulatory care setting is there, thus reducing the patient length of stay, patient safety, and complication rates per se also. Operating time does not increase. In fact, a meta-analysis shows that it reduces with robotic surgery. And another study which showed that the learning curve, feasibility and safety were there with robotic surgeries per se. And various studies in literature have shown that the learning curve may range from none to at the most 30 cases per se. And in this study, they showed that on one side, the attending spine surgeon did the surgery and the resident performed the pedicle screw placement on the other side, and there were no significant differences, thus showing that the learning curve may not be there in robotic spine surgery per se. Thus, we have ample evidence in the literature published in renowned journals and peer-reviewed literature on accuracy and the usefulness of robotic spine surgery per se. And we have implemented it well in our center here, done a large number of cases with good outcomes and safely in various pathologies per se. And here you can see this osteoporotic patient with a compression fracture with neurological deficit, which we did by an MIS technique using robotic technology. So, from the initial robotic systems which were there, a lot has changed from what they could mainly achieve an accurate drilling trajectory. The present generations can plan, simulate surgical outcome, execute, and navigate instrumentation in real time. What has led to the progress has been mainly artificial intelligence, the collecting data from previous generation robots and putting it in latest generation robots to achieve the desired outcomes with utmost accuracy has been the key per se. So there are various features which are there in the current generation robotics, like automated assessment of patient global balance, seamless O-arm integration for registration and planning, bone mounting options which enables posterior fixation from a lateral position, enables insertion of sacroiliac joint cages, integration of navigation and third generation major spine robotics. and also a tool to bend the rod as per the surgical plan per se. So what we can't do at the moment is decompression can't be assessed, rod alignment can't be done, fusion and rod placement can't be done at the moment. So do we want the robots to do most of the job planned by the surgeon yet leave the last step of the haptic feedback with themselves? Or do we want the robots to completely automate the procedure, replacing the surgeon? Maybe by putting the surgeon behind a video game console, like is done for various surgical procedures, is the query that we face. So in the future, we should be able to have automatic planning. We should be able to use MRI also for planning, thereby minimizing radiation. Construct execution, rod bending should be possible, and various operating room devices could be integrated per se. So the take-home message, friends, would be that it is a fact that robotic-assisted spinal surgery, as per current evidence, is more accurate, more efficient, and safer for minimally invasive pedicle screw instrumentation in spine surgery compared to traditional fluoroscopic-assisted freehand or navigation approaches. Literature has also proven that there is no significant learning curve. Level 1 evidence is required to increase the statistical power of these conclusions and define its future applications, limitations, and areas of improvement. With the evolving technology, future generations of robots have immense potential to improve spine surgery for both patients and providers alike. That the spine robotics will replace humans seems to be a fiction. What we witness today may be building steps to the definition of routine spine surgery in the future. And hence, for the best use of technology, the surgeon and robo both need to understand each other interchangeably. So if one has not started, let's do that now before it is too late, because it is a very useful technology and has a great potential for the future. Thank you for your patience, and I will be happy to answer any questions.